looking at cigarette smoke and water pipe, I guess. Can you also study e-cigarettes with that, and are there effects?
Yeah, so we've been asked to try to look at that because our models are so robust and reproducible now. The problem is there's not a good machine to actually capture the condensates from e-cigarettes. And so the CDC and the regulatory committees at the NCR are looking into contracting for a machine to do that. And once the one is available, we'll probably be asked to start to look at that. I think we've tried to use this as a model for carcinogenesis to try to define epigenetic mechanisms related to malignancy, but also to identify new targets for therapy. And I think it's been fairly rewarding, but it comes with all the caveats, as you might expect, with trying to use in vitro model systems to mimic in vivo exposures. That's been particularly difficult as we've tried to mimic water pipe smoking.
Mm-hmm. Mary Jo.
A question on the PD-L1 staining. Have you seen any difference from what has been reported in the different mesothelioma subtypes?
So we concur that there is a higher rate in the sarcomatoids over the epithelials.
And Hedy, so you presented a lot of trials, from competing companies. What's unclear to me is what's actually the approval strategy. So you have a signal already with responses. So what will lead to FDA approval of one of these drugs?
And the one drug which is closest to pursuing that, I can't talk about. So.
All right. Sorry, I asked.
But yeah.
Okay. So good. So there appears to be an approval strategy, but it is not something we can discuss. And why not just add it to PEMCIS?
So there is a study, the DERVA study is being planned in Australia and Canada to add to PEMCIS.
Mm-hmm. John?
Just a really quick one. The determined trial.
Wait, can I actually finish up? But it would have to possibly also add in BEV.
Yeah.
But it depends on what country they do it in. So that could be also an issue. Yes.
The determined trial, when I saw on your slide, I thought you said it was 500 patients, but it was a 2B.
Mm-hmm.
Is that correct? They called it a 2B?
They're calling it a 2B, and yet they're trying to make it a 3.
Yeah. Because that it's an interesting, because it's on how companies.
Yeah.
Yeah, because if it's truly a 2B, it's a comparative trial, not so so if we had a statistician in the room, they may not like that, but okay, so that is what it said. And then the other is the epigenetics, is that approach, because conceptually from my standpoint is that again, genetic mutations are not a good way for a cell to adapt to stresses on it, but epigenetics is, and that's probably how they survive a lot. And so with that approach and with mithromycin, is that a drug that may be able to combine with the other targeted or PD-1s to prevent the adaptive strategies that cells do to survive the whatever stress, be it a targeted therapy, a chemotherapy, or a immunotherapy?
Sure. So I actually changed my my talk considerably after seeing all the checkpoint inhibitor presentations, and thought I would talk a little bit about the mithromycin story. We actually have over the years have really tried to use chromatin remodeling agents. We've studied. Had a number of papers in which we were looking at basic mechanisms of upregulation or derepression of cancer testis genes. Because as we've studied that, we've really been trying to look at fundamental mechanisms of DNA hypomethylation. What's driving that phenomenon? How are cancer testis genes derepressed? Because they're not all derepressed simultaneously. They're coordinately derepressed. We actually reprogram normal human cells specifically to try to address the issue of, is it just global DNA demethylation that is causing this phenomenon, or is there something else that is required? And as a correlative to that, we have actually really all of our papers over the past 15 years have been to try to use these gene induction regimens with immunotherapy. Several years ago, when I was still working in the surgery branch, we had actually, Steve Rosenberg and I had discussed using a decitabine induction regimen with adoptive transfer of MAGE-3 TCRs. Unfortunately, at the time, that the MAGE-3 TCR turned out to be too toxic, and so, in sort of, we went through a couple of years at the NCI where I really had no access to some of the, decitabine and so forth, because they were no longer in CTEP, and there was a cost shifting to the PIs for off-label use, and it was very difficult to get that. We now actually have a trial in which we have access to oral decitabine. The NCI is actually formulated and encapsulated. It's going to be used in combination with tetrahydrouridine, which is the inhibitor of cytidine deaminase. We have in vivo data with primates as well as sickle cell patients showing that this oral regimen actually gives Cmax of decitabine that's in the 50 nanomolar range and extends the half-life or the duration out from about 5 minutes to 4 or 5 hours. So that clearly puts us in the threshold regimen where we saw upregulation of CT antigens in our phase 1 study for decitabine. So that's actually going to be combined with a tumor lysate vaccine that we've developed in our laboratory. We have the IND for, where we've seen about 4 out of 7 of the first patients are immunologic responders in a blinded analysis in conjunction with nivolumab. So I'm very pleased that all of these years of trying to, get to this proof of concept trial may actually be soon to happen.
Great. So, John, can we end a little early? You want to take a break?
Yeah, I think this would be great. And then why don't we take a little bit, we do have the breakout session. And we, just so you know, we have a Dr. Zhang, and then we have 2 of the poster presenters who do it. So what I would say is, if we want, we could take about 10 minutes break, grab coffee, use the restroom, and then we'll do that session. We'll probably be done with the whole session here, probably by about noon.